Hi, everyone. This is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. We are accustomed to using urinary cytology in our management of patients with bladder cancer and also in certain patients with hematuria. But we do know that there are limitations to cytology, particularly its sensitivity. We know that the positive predictive value is very high when the test is positive. Recently, there has been an adjunct that has been developed to be used in concert with urinary cytology, something called Uro17. This is a test which increases, and we'll hear from one of the developers here, John Cucci, from Acupath, on the value of Uro17 and the diagnosis and management of bladder cancer. John, thanks for joining us and sharing with us this new information.
Dr. Crawford, thank you very much for the introduction. Appreciate the opportunity to speak to your audience about the role of the Uro17 urinary biomarker in the diagnosis and management of bladder cancer. My name is John Cucci. I'm an executive at Acupath Laboratories and a leader with regards to the introduction of Uro17 to the marketplace here in the United States and abroad. Acupath Laboratories is a uropathology laboratory based in Long Island. We're an in-network laboratory. It's been around for over 20 years. Some of the advisors that we've worked with on Uro17 include Dr. Seema Porton from UCSF, Dr. Tom Jayram from Urology Associates in Nashville, Tennessee, and Dr. Nikhil Vasdev from the United Kingdom, who recently authored a paper that we'll touch on during the presentation. Uro17 was founded by Dr. Ken Schroyer, chairman of pathology at Stony Brook University. And what Uro17 is an antibody that detects the expression of keratin 17, which is identified in several different types of cancers, but very closely correlated with bladder cancer. And it's unique in that the expression of keratin 17 happens earlier than urine cytology, changes to urine cytology that would be visible there, or genetic changes that are visible during a Eurovision FISH test. So, the goal here of the assay is to address the significant shortcomings of both cytology and FISH, specifically with regards to those tests' inability to diagnose low-grade disease and addressing cytology's overall low sensitivity. So we believe at Acupath that there is a significant unmet need for a non-invasive and cost-effective screening tool. Uro17 is detected very simplistically via immunocytochemistry, which is a stain utilized in conjunction with urine cytology, or perhaps as a standalone test, and is interpreted by a cytopathologist. It's highly sensitive and specific, over 95% per the published papers that are available to your audience, which I'll touch on during the presentation. So it's highly sensitive and specific, non-invasive. And we launched it at Acupath in July of 2019. We were the first laboratory to do so worldwide. And to date, we've completed over 10,000 cases. So we have many significant case studies available demonstrating the assay's significant clinical utility. The success of the assay was recognized by the FDA in November of 2019 when it was designated as a breakthrough. And that fast-tracked a clinical trial that we are in the midst of right now, working with several LUGPA practices across the country on a trial comparing and contrasting urine cytology, Uro17, and Eurovision FISH. And we welcome additional sites that would like to participate in that study. The marker also received its European CE mark in 2020, is being utilized in the UK, and is generating significant interest around the world. Here in the United States, it is billed as an 88360, which is a commonly billed laboratory code. So the benefit of that is that it is paid in network by virtually all payers. And as I mentioned previously, it's cost effective with Medicare reimbursement at around $125 to $150, which is significantly less than many of the other urinary biomarkers that have come out in recent years, especially those molecular markers that are also often not paid by payers. So this minimizes headaches for patients and providers and for insurance plans, while still contributing significantly with regards to clinical utility. Speaking of clinical utility, the primary application of this marker is a screening tool for hematuria patients. Also can be adapted for the monitoring of those patients for monitoring for long-term recurrence of bladder cancer post-therapy. The 100% negative predictive value and the ability to confirm a negative urine cytology is a benefit that our urology clients have expressed to us. They've found that very useful, because a benign urine cytology on its own, due to its low sensitivity, how do you truly have confidence in that result? With our Uro17 tests, 100% negative predictive value, a negative urine cytology with a negative Uro17, you can have confidence in that result, that that patient has a very low or no risk of bladder cancer at that time. The assay is also used as a risk stratification tool for patients that either have a negative urine cytology result or an atypical result. So again, a negative Uro17 result with a cytology would downgrade that patient. Conversely, a positive Uro17 result, and especially a high positive result, would indicate that that patient warrants additional follow-up, whether that's cystoscopy, Eurovision FISH, or some other diagnostic follow-up. So our clients have used this as a cost-effective risk stratification tool for those patients. With regards to the diagnosis categories, we have 4 categories: negative, equivocal, low positive, and high positive. This has been established with evaluating, over the 10,000 cases that I mentioned previously, and in consultation with our clientele to identify appropriate cutoff levels. The most significant area would be the high positive result, which is a strong indication that this patient has a tumor present or is in the process of developing one, and certainly requires a follow-up and an aggressive diagnostic workup, very likely a cystoscopy and other testing. Low positive and equivocal are both abnormal results that shrink the window of time that a patient may be seen for follow-up. So they're patients to keep an eye on. They're not certainly not benign patients. These are significant results that, while they haven't yet hit the high positive category, those are patients that you want to shrink your time for surveillance. And again, it's a voided urine specimen, so not very difficult to have a patient return to the office to provide that specimen. Uro17, the value of which is highlighted by Dr. Tom Jram, who's the director of Urology Associates in Nashville, Tennessee, and a leading bladder cancer expert in the United States. Says that he's been using this test for 1.5 years as a simple, inexpensive urinary biomarker that has tremendous potential in point-of-service testing for patients with suspected urothelial carcinoma. I found it to be a significant upgrade over traditional cytology in the detection of both high and low-grade urothelial carcinoma. In my experience, a negative Uro17 is extremely meaningful and reliable in triaging patients away from invasive procedures. Furthermore, Uro17 has been able to adjudicate indeterminate cytology results and allow me to better tailor surveillance schedules in patients with a history of bladder cancer. So great feedback from a leading bladder cancer authority here in the United States. And, this is a sample of a report that Dr. Jram would receive, or your clients would receive, combines urine cytology with Uro17 in one very easy to interpret report. And lastly, these are 2 of this published studies that are available to your audience that we can certainly provide a copy. The most recent study came out in 2021. Uro17 is available commercially in the United States for urology practices, for other commercial laboratories that we perhaps would partner with, or for hospitals. Can be done on a TCPC basis if you have your own pathologist at your practice, or can be brought in-house entirely if you have your own laboratory. And with that, thank you very much. Please reach out to me for more information. Thank you, Dr. Crawford, for the opportunity.